presentations that have been an event in the Department of Medicine for many decades. Usually there's 3 presentations made on a Thursday afternoon. For these ECHO webinars, we've reduced it to 2 presentations, each 15 minutes long, and that allows for 15 minutes after each presentation for discussion, to hear the inputs of consultants and other colleagues regarding the case, and time for questions in that discussion session. So we'd encourage you to post questions that you have regarding the case or regarding the condition in the chat function, and those can be addressed in that 15 minutes of discussion. So we have 2 cases this afternoon, and I'll introduce the first case, which is presented on behalf of the Division of Neurology by Drs Oosthuizen with the consultant MV Boole. And the case is a case of hemichorea. So just want to see if Katrine is able to share her slides and unmute, and then we could go ahead.
Yes, thank you very much. We can unmute, and I'm just going to share our slides.
And I'll tell you if everything's okay. Just needs to be in presentation mode. Yeah, that's all coming through clearly, Katrine.
All right, thank you very much. Yes, so I will be presenting on behalf of the Division of Neurology a case of hyperglycemic non-ketotic hemichorea. So the patient I'm going to be presenting is a 74-year-old woman who was an inpatient at Aquarius Rehabilitation Centre following a recent right partial anterior circulation stroke when these symptoms occurred. She's got a background history of multiple cardiovascular risk factors, including poorly controlled type 2 diabetes. So 1 week after her admission to Aquarius and 2 weeks prior to a review with us at Groote, she developed acute onset involuntary movements of her right arm and leg. These movements are noted to have started overnight, having been absent the previous day and present when she woke up the next morning. She had no associated confusion or episodes of impaired awareness, and otherwise she was systemically well. So on examination, excuse my very amateur editing of this video, but we just wanted to occlude her face. So on examination, one can know she was noted to have hemichorea involving her right arm and also her right leg. These movements fluctuated in amplitude and frequency, and the staff noted that sometimes there were no abnormal movements at all for 2 or 3 hours. She was unable to voluntarily completely suppress the movements, but the amplitude did decrease when she concentrated on other motor tasks, such as dressing or using cutlery. And according to the collateral history, the movements were also present when she was asleep. On examination, there was no weakness or altered sensation of the right arm or leg, no impaired coordination. She just had the residual left hemiparesis from her recent stroke. So at this time, the main concern from the medical staff at Aquarius was of a possibly another stroke. But what other causes of the hemichorea might one have considered at that stage? Certainly a stroke in a known patient with multiple cardiovascular risk factors is a major concern. Very often one would have negative symptoms associated with that, but an isolated stroke in the subthalamic nucleus can just present with hemibilismus. One might have considered other causes as well, metabolic causes or possible structural causes, but Aquarius was concerned about a stroke and sent her to Mitchell's Plain Hospital for CT brain. So on arrival at Mitchell's Plain Hospital, a CT brain was performed. There was no stroke on the CT brain. The report noted no acute pathology and incidental bilateral basal ganglia calcifications. As you can see on the screen here, the high density in the basal ganglia bilaterally. Basic blood workup was essentially unremarkable. Her renal function was unchanged from her baseline, and she was noted to have an HbA1c of 14%. She was subsequently referred to our neurology department for review, and she was seen at our outpatient clinic. At that stage, her HDT was 10.4, and her hemichorea was noted to be less pronounced than that seen at Aquarius, but it was still evident. So our thought process at the time was this is an elderly female with a history of poorly controlled diabetes, new onset hemichorea, and hyperdense basal ganglia on her CT. And this raised our concern of hyperglycemic non-ketotic hematuria. And I hope that by the end of my presentation, if you are faced with a similar picture, that might form part of your differential as well. Consequently, we requested an MRI brain to aid in confirming our clinical suspicion. So her MRI brain was performed, and as you can see on these images, this is a T1 image of her MRI brain. You can see there's hyperintensity in both her basal ganglia. So the T1 image, we've got different views on MRI. T1 image enhances fat and suppresses fluid, and our T2 views accentuate fluid and suppress fat. So the T1 images are useful to view anatomy. And as you can see here, there's a high signal in both basal ganglia. So we were confident of our suspected clinical diagnosis of hyperglycemic non-ketotic hematuria. This is a condition characterized by non-ketotic hyperglycemia, usually in elderly, poorly controlled by diabetics. Involuntary choreiform movements, which is usually unilateral, but can be bilateral in 10% of cases, and basal ganglia hyperintensity on T1 weighted MR imaging, which one can also appreciate as high density on CT scans. These aren't features typically seen in strokes. Other terms have been used to describe the condition in the past. In the early 1900s, the condition was already well known on autopsy findings, described as diabetic striatopathy, and the term chorea hyperglycemic basal ganglia syndrome has also been used. So this condition has a prevalence, which has been reported to be up to 1 in every 100,000 patients, usually in elderly patients, and it has a female predilection. The presentation of the involuntary movements are varied. They could start abruptly or insidiously. They could be low amplitude or high amplitude. They could manifest intermittently or be continuous. And for most patients, the chorea worsens during nervousness and often disappears with sleep, though this is not always the case. Here are just a few other images of other patients with the same condition, just to show how these might present. So over on this view, you can, on the first screen on your left, you'll see this patient just has a hemichorea involving the arm and the leg. The patient on the far right has got bilateral chorea, but much more significant on the right. And the patient in the center as well, it is also bilateral, but even in that case, you will note that one side is usually more severely affected than the other. So radiographic features of the condition. As you noted, CT brain, it can initially be normal. One then develops these subtle hyperdensities in the basal ganglia, which is usually unilateral, but can be bilateral as well. If it is unilateral, it is always contralateral to the body side affected by the hemichoreic movements. MRI-weighted imaging, as we noted, one typically sees T1 hyperintensity and very often on T2 weighted imaging, the lesions appear hypointense. So here, for instance, one can see the differences. Here you can see on the T1 weighted imaging, the basal ganglia appear very bright. They are hyperintense, but on the corresponding T2 weighted imaging, they are hypointense. Of course, there are various causes for high signal in the basal ganglia on imaging. It is important to consider when one looks at these images that in hyperglycemic hemichorea, only the basal ganglia have T1 high signal changes, not the brain stem, cerebella, brain parenchyma, etc. Other causes one might consider are various toxins, such as manganese, for example, or previous linear gadolinium chelates, as well as conditions such as copper in Wilson's disease, and blood could also give an initial high signal on the CT scan, but it does have different characteristics to distinguish it initially. So marked T1 basal ganglia hyperintensity is the most characteristic radiological finding of the disease, and combined with hyperglycemia and the presence of chorea, it is highly suggestive of the condition. There is a general agreement that the occurrence of chorea is due to dysfunction of the basal ganglia, but to date, the exact pathogenetic mechanisms of the hyperglycemic hematuria and the nature of the neuroradiological findings are still unclear, though there are several theories and hypotheses, and I will describe some of them. So one of the most popular theories is the ischemic injury or iron deposition theory. Here it's postulated that microvascular ischemic injury results in proliferation of astrocyte and expression of zinc-friendly metalloproteins, which will lead to a high T1 signal on MR imaging. And on studies, scholars have actually found that local ischemic injury can induce the accumulation of manganese ions in the rat striatum astrocytes, which also results in paramagnetism. There are also neurodegeneration theories considering possible demyelination and swollen and reactive astrocytes, but these theories do not fully explain the radiological pictures that we see. Looking at our pathophysiology, one of the most broadly viewed theories is of metabolic disorder theory. So in states of hyperglycemia, the brain tissue obtains energy by anaerobic metabolism. And during anaerobic metabolism, the main energy source for the brain cells is gamma aminobutyric acid, which, if you will remember, GABA is also the brain's primary inhibitory neurotransmitter. So GABA can be synthesized from acetoacetic acid, which is produced in the liver in ketotic hyperglycemic patients, but not in non-ketotic hyperglycemic patients. Consequently, in non-ketotic hyperglycemia, there's a rapid depletion of GABA in the brain during anaerobic metabolism, and this results in disinhibition of the subthalamus and basal ganglia, which leads to hyperkinetic movements. Of course, based on this theory, chorea should probably be bilateral, but we know that in most cases it is actually only unilateral. Synergistic to this is the role of dopamine. In hyperglycemic states, we know the level of dopamine increases, and we know that an increased levels of dopamine weakens the inhibitory effect of the basal ganglia. Consequently, most scholars currently speculate that pathogenesis of hyperglycemic non-ketotic hematuria involves the altered GABA and dopaminergic neurotransmission, with depletion of GABA, which is used as an alternate energy substrate during a hyperglycemic crisis, causing decreased inhibition of the basal ganglia, and chronic hyperglycemia leading to changes in dopaminergic activity in the basal ganglia of predisposed patients. The good news is that the prognosis for this condition is generally very good, and chorea can often be treated successfully with glucose control alone. In non-responders or patients with severe symptoms, dopamine receptor antagonists such as haloperidol, risperidone, or clonazepam may also relieve symptoms. And there has been studies which have demonstrated a role for surgery in refractory cases. So this is one study. It's one of the bigger meta-analyses. We only have very small case series. So this is actually a meta-analysis with 172 patients. And on the left of your screen, so these patients were not randomized. These were real life management choices for patients. So you'll see of the 172 patients, a quarter of them were only managed with glucose control, and most of them had complete liver resolution. And then the rest of the patients were managed with glucose control and anti-chorea treatment. So chorea was successfully treated with only glucose control in about a quarter of patients. 80% of patients had complete resolution with a combination of glucose control and anti-chorea medication. Symptom improvement typically started within 2 days, with full recovery in 14 days. And it is interesting to note that pre-treatment chorea duration had no significant impact on recovery time. Only 5% of patients did not show any response to first-line treatment, and many of those patients were subsequently considered for surgery. It's also interesting to note that the imaging anomalies actually improve, with resolution typically seen at 3 months on CT scan and at 8 months on MRI imaging. Unfortunately, recurrence is common if glucose control is not maintained. So the takeaway message from this talk In a diabetic patient with hemichuria, please consider hypoglycemic non-ketotic hemichuria. Thank you.
Thanks, Katrine, for an excellent and educational presentation. And we have plenty of time for comments and discussion. So over to MV Gule, who was the consultant on the case.
So yeah, I just want to thank Katrine for presenting again. I think this is the third time in the last year she presented in the Thursday forum for us. And just from my point of view on this condition, it's very, very rare, but we don't see it infrequently. I think about once or twice a year, we get a referral from the G floor with a patient with a similar presentation. And often it's very dramatic, both for the patient and for the managing team. And I think it's useful to know that the prognosis overall is good. The other point I want to make is just kind of in neurology, the primacy of glucose control, both in the hyperglycemic and the hypoglycemic states. We often very easily recognize hypoglycemia, but, we treat acute strokes, and we know that acute strokes do worse when they have hyperglycemia at the same time. And so I think it's always important to consider what's what's happening with glucose control in patients with neurological problems, and that also glucose can affect the nervous system in many, many, many different ways. I'd be happy to take any questions or comments.
Thanks, MV. Are there any questions at this stage? If not, we can go on to Kathleen Baker and Lawrence Tucker, if there's anything that you would like to add.
Yeah, thanks, Katrine, and thanks, Graham, and thank you, MV. I don't have too much to add. I think I just wanted to point out clinically the relationship between hemibolism and hemichuria. From a neurologist perspective, we view these as a continuum. So whilst hemibolism is a very wild flinging motion, and hemichuria is a smaller motion, frequently if someone starts with hemibolism, they may resolve into a hemichuria state. So I think it's always worth asking patients for the history of the onset and not being surprised if there's hemibolism as part of the description. I think the second thing to say is that I do want to point out that if you've had it before, we do see patients relapse with worsening glucose control. So there does seem to be an increased vulnerability to develop this in an individual who's had it once before, and even with only mildly abnormal glucose control. And whilst the clinical syndrome does tend to improve in the majority of patients, we do tend to, in fact, more often than not, still see some radiological features which suggest that it was present, although these findings are non-specific and there's quite a broad differential. So we do, as Katrine elegantly pointed out, view it as a metabolic insult primarily rather than an ischemic one, although there is an argument to be made, and in truth, we don't honestly know why this occurs. Yeah, those really are the only comments I wanted to dwell on. Thanks.
Thanks, Kathleen. And Lawrence?
Yeah. Thank you. I don't think there's a huge amount else to add. It is, the etiology is speculative. There are theories and proponents of each of the theories. I think, again, just to reiterate that that the treatment is beneficial in most patients, but not all. So only a quarter, if you look at it that way, only a quarter respond just to glucose control, and then you need pharmacological intervention like haloperidol in another 2/3, and then there's a small percentage that actually do poorly, and surgery is often successful in those patients. And the other interesting thing is that with good glucose control, the relatively dramatic lesions that are seen on the imaging can improve as well. So there is a reversibility to the imaging findings as well. But I think the subject's been really quite nicely covered by the other speakers. Thanks.
Can I ask one question, and then I'm going to hand over to Mark, who's got a question. Just the actual glucose levels in this patient, at what level of glucose was the patient experiencing the hemicrania? I think you mentioned 12, but did it go higher? And secondly, what range of glucose control do you aim for to achieve resolution of the features of this condition?
So I can answer. Her HbA1c was 14. Her glucose when she presented to us was 10.8. And it might be useful to note that sometimes one can actually manifest with these abnormal movements during rapid changes in serum glucose. So for instance, if a patient had terrible glucose control, they get admitted to hospital, all of a sudden they have really, really strict glucose control. You might actually manifest in that glucose transition period with these abnormal movements as well. So they can sometimes manifest when you once quickly controls glucose, but otherwise they have been described in low, high glucose levels. So one doesn't need an HbA1c of 14. They have been described in patients with HbA1cs of 8s, HbA1cs of 9s. So not terrible glucose control. The exact glucose we aim for resolution of symptoms, Envy, I don't know, less than 6.5.
I'm getting a look like I have a number. I don't have a number, but I think we should be aiming for the same kind of glucose control we would aim for everybody else in the ward. And I think sometimes you have to be reasonable about it. And if the patient's at a big risk for hypoglycemia, you might have to be a little bit more permissive, but understand the risk that you're taking with the patient.
So it's the standard targets that you would choose in type 2 diabetes.
Yeah, that's my understanding, yes.
Thanks, Graham. To my neurology colleagues, I mean, just a thought, and as a follow-on from Graham, one wonders if this is, and understandably, as you said, the pathogenesis is really not clear, but whether the glucose is really the issue here, or a surrogate marker of vascular dysfunction and a vasculopathy, and you're getting somebody who's got baseline suboptimal glycemic control, and then maybe getting these spikes, and that sort of sets things off, and that it's actually suggesting a vascular process, and the sugar is just a surrogate marker. I mean, I'm saying this because I think we have to accept that glycemic control in our absolutely, explosion of diabetics we have is generally not fantastic. And in fact, 8 to 14, A1C is the range. And yet, MV, as you were saying, we do see this, but it's not a common issue. So one wonders, I mean, I'm just sort of thinking out loud, any thoughts?
Well, what I would say is, again, it happens in elderly people who have vascular risk factors to start off with. However, radiologically, it really doesn't behave like a stroke. So if anything, it's the opposite of what a stroke would behave like in the long term. And the fact that these features are reversible with the glucose control is also, I think it points to the fact that the glucose plays a significant role. It might be that there's underlying ischemia, there probably is, but I do think, when we look at MRIs, we would expect an entirely different picture if it was an ischemic stroke.
Thank you. Kathleen, your hand is up.
Yeah, if I can make a comment on that, Mark, I mean, I think your question is a very valid one, and I completely agree with Envy. I think just if you look at it, there are situations in the brain where unusual forms of ischemia manifest differently on MRI scans. So, for example, there's selective neuronal vulnerability in places of the brain that we know how to recognize as ischemia. And it is also true to say that, so is something similar happening in the basal ganglia? Possibly. There is some histological evidence of an obliterative vasculopathy occurring selectively in the striatum in some cases that have been described and gone to autopsy. However, it's a very unusual radiological perspective. And when you get that T2 high signal, quite often T1 high signal rather, what's often present is thought to be highly proteinaceous material intracellularly. So it may be that a form of selective ischemia is changing intracellular processes in a way that raises the content of a substance inside those cells the mechanism of which may include ischemia, but I don't think we really know. And what we do know is that it definitely disrupts the GABA dopamine balance in the basal ganglia in a way which produces a dopaminergic state. And that would be the crude explanation of a summary of where I think the literature is at the moment on pathogenesis.
And Katrine, can I, or MV, can I ask, you know, the MRI findings that you described with the high density on the T1 weighted MRI, is it understood what that reflects, or do people not really have an idea of what that process that's reflecting?
So, as I say, there are theories that it's either metalloproteins, which can be either zinc or manganese. Both of those are shown in autopsy findings, which would be paramagnetic. Some of the features, like Dr. Bateman mentioned, the high cellular protein, obviously highly proteinaceous material in the cytoplasm inhibits the movement of water molecules. That will show up with the T1 hyperintensity on MRI, but that won't necessarily show high density on the CT brain. So explain the MRI findings, but not necessarily the CT findings. So at this point, the main theory is that it is the paramagnetic deposition. Yeah.
So, Katrine, I don't know whether I was on mute when you immediately finished your talk. Just to say thank you very much. Really excellent presentation and very educational session. So we're going to move on to the second case, which is a presentation from pulmonology that Wendy is going to introduce.
So our next presenter is Dr. Drs Vorajee. She's going to present on the part of Division of Pulmonology on forbidden cherries, and her consultant is Dr. Ali Ismail. Nadia, you can start sharing your slides.
Thanks so much, Prof. Can everybody see that?
Yeah, we can see.
Okay. So as Prof mentioned, my topic today is the forbidden cherries, and really it's a case series of 4 cases of a pulmonary carcinoid, which we've seen in the last few years through the respiratory clinic. I really just want to sort of run you through an introduction to what pulmonary carcinoid is. We'll look at the WHO classification of lung neuroendocrine carcinomas, and then we'll focus a bit more on your atypical versus your typical pulmonary carcinoid. I'll talk a little bit about our cases, and then we'll run through how we investigated them and other investigations that one could do, how our cases were managed, and then just to end off, we'll just look at carcinoid syndrome and why it doesn't usually occur in pulmonary carcinoid. So pulmonary carcinoid is quite an uncommon lung carcinoma. Depends on the text that you read, but its incidence is noted to be between 0.5 and 2% of all lung cancers. It's part of the spectrum of neuroendocrine tumors, and it's about 20 to 30% of all neuroendocrine tumors. The majority of them occur centrally, with about 20% of them occurring peripherally. They are all malignant and they can metastasize, which I think is an important note to make. There is some association with smoking, but it hasn't been proven to be causal, and definitely more significantly associated with your atypical group. And they often arise from sort of the cells that are present in your bronchial epithelium and your bronchial mucosa. So the WHO classification really looks at the histology of these tumors and comes up with a grading for them dependent on both their mitotic activity as well as their cell type. So for your typical carcinoid, it's usually low grade and well differentiated. Your atypical carcinoid is intermediate grade and poorly differentiated. And then you've got your large cell neuroendocrine carcinoma and your small cell lung cancers, which are your high grade cancers. We'll really be focusing on this group, the typical and atypical carcinoids. So I utilized this table from a review article, which quite nicely depicts the differences between typical and atypical carcinoid. As you can see, the typical carcinoid is far more common than the atypical. The typical also has a better 5-year survival and a better prognosis. And then, as I mentioned earlier, your atypical is associated with a history of smoking. There's some sort of discrepancy in the data that you read. Typical carcinoid is more common in females, but some of the studies have noted a male predominance. And then definitely your typical carcinoid occurring in a younger population as opposed to the atypical carcinoid. In fact, your mean age is about 47. Usually the typical carcinoids are smaller tumors and rarely will metastasize, and we'll just go through a few of the features when we discuss some of the literature a little bit later. So what about our cherries, our 4 patients? So the majority of our patients were female. Our youngest was 14 and our oldest was 34. As you can see, the predominant symptom in our patients was cough and dyspnea, and then close behind was hemoptysis. And very rarely did our patients present with constitutional symptoms. And we had no patients present with any typical syndromes, and we'll go through a few of those later on. All of our patients were diagnosed with typical carcinoid, and the size of the tumors was more than 3 centimeters. And because they were typical, they were more likely to be central, and our patients were central. Of note is that I just want you to see that all of our patients had evidence of bronchial or airway obstruction, which in other people's cherries in the literature is not so common. So as mentioned before, the mean age is usually 47, although there is a spectrum. So your age groups, your age group is usually from sort of 35 to about 55 for your typical, and your atypical much older. But definitely your typical carcinoids have been described in a younger population. And as you saw, one of our patients was actually 14. Most of the carcinoids in the literature were noted to be asymptomatic and were picked up really on routine screening or when patients presented with other clinical problems. Those who were symptomatic, the majority of them had presented with hemoptysis and then dyspnea and cough. And then rare presentations were that of carcinoid syndrome, so less than 1% of patients. And then in metabolically active tumors, you could get Cushing's syndrome, which is an ACTH secreting tumor, or even acromegaly. And again, just noting a rare presentation of this post-obstructive atelectasis. You know, one could postulate that perhaps our patients are presenting later, and the tumors are quite large, and hence they are presenting with airway obstruction. It might just speak to our access to actually getting imaging for our patients when we're out in the periphery. So the investigations, I always like to start off with your bedside investigations. So I think in these patients, you'd like to consider doing a finger prick glucose, particularly if you're worried about an ACTH or Cushing's syndrome from these tumors, and then a baseline oxygenation or ABG, depending on what the oxygen sats are. And then not to forget that carcinoid is a very rare cause of heart failure and can cause fibrosis of the valves. So you want to just be sure that the ECG is normal. These are usually the tumors that secrete metabolically active substances. So again, would be less likely in the setting of lung carcinoid. Your laboratory investigations, so you really want to make sure that your routine baseline investigations, the UNE and FBC, are normal, because this may impact treatment and may also impact whether or not you can give contrast in your CT scan. And then specific tumor markers really are not very helpful in lung carcinoid. As mentioned, these tumors do not usually secrete bioactive products, but if you are concerned that your patient is presenting with a carcinoid syndrome, then you may consider doing serum chromogranin A. just be careful with the chromogranin. We know that it is not very specific, and it can be raised in other conditions that are completely unrelated to the malignancy. And then your urinary hydroxyindole acetic acid, again, not commonly found in your lung carcinoids. Perhaps if the patient is having a carcinoid syndrome, one could test for it. But I'll touch base again on why urinary hydroxyindole acetic acid isn't raised in patients with lung carcinoid. So your imaging, you'd start off with a chest X-ray, and remember always to do an abdominal ultrasound. These patients will often have liver metastases. And then you want to move on to more definitive chest imaging in the form of a CT chest. And you really want to look at the position of the tumor, the size, the extent, and whether or not there's nodal involvement. In the literature, there is some evidence to suggest the use of somatostatin receptor-based imaging and nuclear studies, primarily with gadolinium or copper. 60 to 80% of both atypical and typical neuroendocrine tumors will display some somatostatin receptor positivity on immunohistochemistry, which we usually test for. And if the tumor is positive, the utility of doing these scans is really to pick up distant metastases where CT scan would not be great. These scans could be utilized. And then really you want to go on to doing a bronchoscopy, particularly if the tumors are central, as in our cases. If the tumor is peripheral, then you could probably go ahead and do a CT-guided fine needle aspirate biopsy to get a diagnosis. But let's just sort of show you a few of the images from our cases. So these are the X-rays of our 4 cases. To note, on the first X-ray, there is sort of what looks like a whiteout of the left lung and a cutoff sign of the left main bronchus. In fact, this is collapse of the left lung. You can see that hemidiaphragm is pulled up, and you've lost the border of the heart border, and you've got some compensatory hyperinflation on the right-hand side. The second case, one notes a very well circumscribed mass in the left hilar area. And then just to note that there is this sort of tail that one can see, suggesting that there may be some obstruction and atelectasis in that upper lobe. And then if we move to this image, quite a nice one displaying a lower lobe collapse with, a right middle lobe collapse with loss of that cardiac border. And then in this patient, and we'll look at this patient's CT scan next, but essentially you've got an air fluid level with sort of a very lucent lung in this area, suggesting that possibly this is all just part of one large abscess. And again, this cutoff sign of the bronchus here and some volume loss with compensatory hyperinflation. So I've just chosen 2 of the CT images. The first image is the patient whose chest X-ray had the air fluid level, and what's nicely evident here is this well circumscribed tumor which is completely blocking off the left main bronchus, and this is the patient with the right lobe collapse, and you can see again there's this tumor which is obstructing the segmental bronchus. So our patients went on to have bronchoscopies, and these are the bronchoscopic images. And now you can probably see why the title of the talk was entitled Cherries, because they really do look quite like well circumscribed exophytic tumors. And we'll start off just with the first one. They often will have this pearly yellow or white appearance, and often have a very vascular appearance. In the case of this tumor, we'll actually look at the bronchoscopy video in a few minutes, but you can see this tumor, there's actually hemorrhage around it. Here you've got lots of vessels, and again that pearly white edge, and here quite vascular again. So why are these cherries forbidden? Well, as you saw in the bronchoscopy images, they are very vascular. The overlying epithelium is quite intact, so your washings and your brushings are almost always unrewarding, and biopsy is really the gold standard in making a diagnosis. But they are highly vascular and they often will bleed. there was a review of about 543 Canadian patients who underwent both flexible and rigid bronchoscopy and biopsy. And of those patients, they noted that 2.6% of the patients, so 15 of them, had a significant hemorrhage. They didn't quantify what they meant by significant hemorrhage, and it was noted that it was the operator's understanding of hemorrhage that made them class this patient into significant hemorrhage. 11 of the patients who had a significant hemorrhage did not require any transfusion or emergency surgery. And only 4 patients needed emergency thoracotomy for massive bleeding. Now, as somebody who's recently started scoping, and I'm sure my colleagues will attest to this, these numbers are quite small. But if you are the person that's doing the bronchoscopy, it's quite unnerving to have somebody hemorrhaging and not actually being able to do much about it. And we'll have a look at the video of a bronchoscopy on one of these patients, and you'll perhaps see what I mean when I talk about the hemorrhage. There were some studies that noted that the risk of hemorrhage was decreased with empiric use of adrenaline solution pre-biopsy. And then some studies have noted an increase in the incidence of carcinoid syndrome on biopsy or surgical manipulation in a metabolically active tumor. And then, as mentioned before, if it's a peripheral tumor, you often want to do a CT-FNA. So I really hope this plays, but this is the bronchoscopy of one of the patients. And you'll see what I mean when I talk about it being quite unnerving if you're the operator. So let's see if it plays. So we're just coming down the trachea, and you can see the carina going down into the left main bronchus, and we're looking at that second order carina. And just above that, in the left upper lobe bronchus, you can see this cherry-like tumor, and there's quite significant hemorrhage around it, and we haven't even touched it. We haven't brushed, and we have not washed, and we have not biopsied it. And this patient actually went on to have a rigid bronchoscopy and biopsy, because on rigid bronchoscopy, there is a little bit of extra room to manage if there is a torrential bleed. Okay, so what is the histological pattern that's important in these patients? I'll just draw your attention to the carcinoid. This is a histology of an atypical carcinoid, and you see these classic spindle-shaped cells, which is quite different to the other malignancies. There's also some trabeculation in this image. And then this is typical carcinoid. It's actually the histology of one of our own patients. And the difference is really that you're seeing sort of these polygonal to cuboidal cell shapes with some trabeculation and a small area of necrosis. This is a OTP stain, and you can see that it's highly positive for OTP. So once these stains are done, we then request immunohistochemistry. And really what we want to calculate is we want to calculate the mitotic index. And we often do that in samples that may be degraded by asking for a Ki67 expression. In tumors that highly express Ki167, there is an increased mitotic index. We also will sometimes ask for a TTF1, which is a thyroid tumor factor 1. The reason we ask for this is because it's sometimes helpful in differentiating a true pulmonary carcinoid from a metastatic carcinoid. And this is purely because your TTF1 is only expressed in thyroid and lung tissue and tissue of the forebrain. So I'm not really going to go through this. I've just put this here, but I'm sure everybody is aware of the TNM classification, and it's exactly the same classification when we talk about lung neuroendocrine carcinomas. So just to be aware that we do use the TNM classification. So what happened to our patients? Well, we picked those cherries. 3 of our patients went on to have surgery, and 1 is booked to see the cardiothoracic team next week. 2 of our patients had pneumonectomies, 1 had a lobectomy, and the patient who's due to see cardiothoracics next week is probably going to end up with a pneumonectomy. So the mainstay of treatment is really surgical resection, either sleeve, wedge, or flap if you're trying to preserve lung parenchyma. But if there's post-obstructive changes, as was seen in all 4 of our cases, or if the tumor is very proximal, then they will often need either lobectomy or pneumonectomy. Adjuvant chemotherapy is not really indicated in patients who have early disease that is curative by resection, but there may be a role in patients who've got advanced disease with nodal involvement where you are trying to aim for cure. And the agents used are primarily etoposide and carbocisplatin. You can see that this is just a table from a review article where these were the cases that were reviewed. And you can see definitely more often used for your atypical as opposed to your typical carcinoids. And that's usually because the atypical carcinoids have metastasized or have early nodal involvement at diagnosis. Your other treatment options, so your somatostatin analogs, as mentioned before, these carcinoids, lung carcinoids, are usually not metabolically active. So again, we often don't use somatostatin analogs in the treatment of our patients. However, if your patient does have a carcinoid syndrome and is non-resectable, there is room for your somatostatin analogs. If you also did a somatostatin receptor a scan, so an octrio scan on your patient, and they did have uptake in distant and in metastases that were noted to be distant, then you can also use them. Not forgetting the liver. So in patients who've got limited liver metastases, you can consider liver resection. And then for patients who have a somatostatin refractory advanced disease, you can consider your mTOR inhibitors such as everolimus. And in patients who don't tolerate these, you can again consider your cytotoxic chemotherapeutic agents, cisplatin or carboplatin, or peptide receptor radioligand therapy, such as your U177 dotatate. There are some smaller studies which are looking at your biologics, so your inhibitors of angiogenesis and your TKI inhibitors. So follow-up. Usually our patients with typical carcinoid will undergo resection, and the majority of them are actually curative, and therefore there isn't real room for follow-up, because there won't be a high percentage of them who will have recurrent, particularly if they had node negative disease. The Commonwealth Neuroendocrine Tumor Society and the North American Neuroendocrine Tumor Society have suggested no surveillance. And as mentioned, if the tumor is very large, more than 3 centimeters, if there's nodal involvement, or if there were close margins on resection or multifocality in the disease, then one can consider following them up. Obviously, if you've got node positive disease or atypical carcinoid, then there is a risk of recurrence, and these patients should be followed up. They suggest history, physical examination, and CT abdomen and chest 6 monthly up until 2 years, and then annually for 10 years. There's really no data to suggest following these patients up more than 10 years is very helpful. And they just note that if they are going to represent, they usually present within those 10 years with recurrence. So now, as promised, I just want to let you know why lung carcinoids do not frequently cause carcinoid syndrome. So just taking us all back to medical school and to embryology, this is the respiratory diverticulum, that little blue outpouching on the diagram. And the respiratory diverticulum usually develops from the foregut along with the stomach, duodenum, and the thymus. And as you can see, carcinoids that develop from these organs often don't have presentation with carcinoid syndrome. So why do normal carcinoids have carcinoid syndrome? And it's really got to do with the formation of serotonin. So within the carcinoid tumor cell, there are 2 enzymes, tryptophan hydroxylase and aromatic L-amino acid decarboxylase, and they change tryptophan to hydroxytryptophan and then to serotonin. The serotonin is stored in little granules and is secreted into the blood, which then mediates the carcinoid syndrome. So what about lung carcinoid? Well, in lung carcinoid, the carcinoid tumor cell doesn't have the aromatic L-amino acid decarboxylase, and therefore you actually get accumulation of 5-hydroxytryptophan plus histamine. And as a result, as mentioned before, you won't get the 5-hydroxyindole acetic acid in the urine. And this is the reason why the majority of lung carcinoids do not actually present with carcinoid syndrome. In the odd chance that they do present with carcinoid syndrome, it's postulated that it's actually histamine driven. So it's slightly atypical to the usual carcinoid syndrome. They say that these patients will often present with flushing and can even present with facial edema, and that flushing and edema will last for about 48 hours. They will also present with epigastric or abdominal pain and diarrhea, as well as a wheeze. So the take-home message is really that these tumors are indolent and they have metastatic potential. We must always think about typical carcinoid in our young non-smokers who are presenting with collapse or hemoptysis. And it should also be considered as a diagnosis in a patient who has been newly diagnosed as asthma or having an atypical wheeze. It's important for us as pulmonologists to weigh the risk of bleeding when we're doing a flexible scope and considering a biopsy. And then just to reiterate that your lung carcinoids rarely secrete active products. So carcinoid syndrome, acromegaly, and Cushing's are really rare, and that the mainstay of treatment, particularly in your typical carcinoids, is surgical resection and then diligent follow-up for atypical carcinoids, as well as typicals with nodal involvement. Thank you very much.
Thanks, Nadia, for a really excellent presentation and overview. Dr. Ishmael, any comments from your side as the consultant?
Thank you very much. I'm just trying to, yes. So just, I'll start by thanking Nadia for presenting this very well. It's a difficult disease, and she's presented it in a very clear and easy way to understand. But the thing that from us is that the reason we've chosen to present this as a case series is just to highlight that although these tumors are regarded as rare, they do come, and we often see 1 to 2 a year. For every one that we see, I estimate there's another one that is missed, and it often takes a catastrophic symptom like hemoptysis or post-obstructive complications for these patients to come to light and receive the treatment that they need. But I think the message out there is to try and find these patients before it comes down to that, so that your patients with recurrent pneumonias who are not getting better, or patients presenting with monophonic wheeze that are treated with asthma medication. And it's important to recognize this in these kind of patients, because as you see that the obstructive complications can firstly lead to destruction of the lung. And instead of having a lung sparing surgery, we now have to resort to pneumonectomies. And secondly, although these are low-grade malignant tumors, they do metastasize. So this the message out there is to recognize these patients and refer them. The best examination in these patients, a starting one that I feel has the highest yield, is a chest X-ray. So recognize these patients and investigate them appropriately. Thank you.
Professor Caligaro, any comments from your side?
Thanks so much. A great presentation, Nadia. I mean, I think the only things I'd like to add is it's one of the commonest lung neoplasms in children, so particularly in that learner. I mean, the causes of lobar collapse in a younger person are generally either foreign body, lymph node, or some kind of endobronchial mass like a carcinoid. I mean, that patient was labeled as having a mucus plug. I think that's very unusual in a major bronchus like a left main bronchus. And also just to add that all lung abscesses should have endobronchial obstruction ruled out by bronchoscopy. And I think that's of relevance to the second or third case where you showed extensive cystic change in the left low lobe because of obstruction. Thanks.
Antila, Gina, anything from your side to contribute?
Thank you, Prof. Thanks, Nadia, for such an excellent presentation. The main thing about these cases is that they basically have curative. It's only one cancer in the respiratory which have a fulfilling outcome when you catch them early. And as we have seen, most of our cases, even though they were discovered, but it was basically late in the presentation. I've actually seen the third one where basically he was presenting in the ER maybe 4 times before we actually saw the patient. And then I'll just say, probably if patient present recurrent with the same sort of symptoms, which are typical of carcinoid or even non-benign lesion, we shouldn't really hesitate to refer them to the respiratory clinic so that they can get a curative treatment. Thank you.
Thanks. Prof. Theodore?
Yeah, Prof. Kirtan is with me. Right.
Sorry, I'm here with Ali. Wendy, I think they've said it all. I don't have anything to add, and thanks again to Nadia for a really great presentation. Thank you.
I've just got a question for the pulmonology colleagues. Obviously, asthma is so common, and this is such a rare condition. Are there any red flags in a newly diagnosed asthmatic that would make you think of this condition, other than what's been said, on the chest, to look carefully at the chest X-rays? Is there anything else that would alert you in terms of the nature of the presentation of asthma to consider this?
Okay, I'll take that, Graham. So essentially, chest X-ray is obviously the most pressing thing, and when there is a lobar collapse, that should make one think that we're dealing with another pathology. I mean, you have to think about mucus plugs, but I think that the wheezing is very different in these cases because it's obstructing usually the larger airways, and it would be like a monophonic wheeze as opposed to a polyphonic wheeze that one sees with asthma. But the take-home message is that if somebody is presenting with asthma-like symptoms for the first time, it's often important to fully investigate this, including with a chest X-ray, but perhaps Greg can add as well.
I was just going to say, just be aware of unilateral wheeze.
Yeah.
Because what this patient had. So I think that would be my clinical sign that I would say that would be atypical for an asthma presentation.
And then Graham, the other comment just is that asthmatics should respond very quickly to inhaled corticosteroids and bronchodilators. And so the expectation is they should respond dramatically. And so I think, a trial of treatment is by all means warranted, but if within a month they are not dramatically better, you really got to start thinking that this isn't asthma. And that's often the problem, is that, patient got query TB, then gets MDR TB, then gets XDR TB therapy before someone thinks that it may be something else. So I think the lack of response to therapy would be one thing that would make us look very quickly at something else.
Yeah, just to add one more thing. I think those are all the clues and the flags, Graham, that you were asking about. Having said that, diseases don't read textbooks, and it's not always a unilateral wheeze, and the lobar collapse takes quite long to manifest. So I have come across patients been seen in clinics for years when somebody thinks of the diagnosis. So it can be missed, and I think it's important to remind ourselves that we need to think of entities like this, particularly when there's not a good response to treatment, or other things don't fit, and so one should have a low index in that situation. But having been trained in the UK as well, and you move between hospitals, and then you're seeing these patients in clinics, and it's only when someone thinks of it and they've been being treated for a long time that the penny drops. So something always to keep in mind. Thanks.
Thanks. Those are really useful points.
Just on a practical side, I mean, the risk of bleeding looks quite frightening. Do you usually notify your cardiothoracic surgeons if you're having a risk like this, where there's potential for one of these tumors with high risk of bleeding, or you just have a friendly cardiothoracic surgeon on call?
Prof, so I'm just going to say the one case that was recently diagnosed about 4 weeks ago, I was lucky enough to be doing my own bronch list for the first time alone. And I don't want to say made the mistake of biopsying and brushing the mass. Thankfully, our patient didn't bleed a lot. I must say the cardiothoracic surgeons are not always available, but are very helpful if we do run into trouble. And generally, because our bronchoscopy theatre is so close, there's often a consultant or a senior fellow around for assistance. So we don't routinely have cardiothoracics on standby, no.
So just to also add to what Nadia said, it's essentially, it's not a contraindication to biopsy, essentially. And you can spray a lot of adrenaline on the tumor before you take a bite, but if a tumor is already bleeding and you think that there's a risk of complications is going to be high, then it's possibly, in those cases, I would not biopsy, and I would actually refer to cardiothoracics for a rigid bronchoscopy. And you can biopsy, you can put the flexible scope through the rigid scope and do the biopsies then, because if there is bleeding, at least you can suction and you can do something about the bleeding and you can cauterize, etc.
So just to add one more thing. Just to add one little bit there, I mean, I think we do, we tend to brush first to gauge the, how much of bleeding there might be. So the biopsy is not contraindicated. We do have cardiothoracic cover on standby, and we have a good relationship with them. The other service we've started now is lung cryobiopsy, where we can biopsy peripheral nodules and also chronic pneumonias, which we otherwise would send for open lung biopsy. We have just launched the service where we have cryobiopsy, where we can obtain these biopsies. And with that, we've also developed some expertise with using bronchial blockers. So that's another thing that we can, in an acute setting, we do have bronchial blockers. These are sort of bulbs that can be inflated, much like a Foley's type of catheter, that you can insert, that can be used as a holding measure. So, we do have things that we can do whilst we, get help and things like that. But it's not something that's really been a major issue and that we routinely do under rigid bronchoscopy. Thanks.
Thanks, Kevin. Nadia, can I ask you to stop sharing the screen? Okay, so I think we're going to conclude this afternoon's session. Just to say a very big thank you to Katrine and Nadia for two fantastic presentations. A very educational session. We've learned about two important conditions, although rare, important to be aware of them because patients can really benefit from making a diagnosis and intervening, as we've seen. Our next echo case discussion echo will be in 2 weeks' time on the 1st of December. And we'll be hearing from the Infectious Diseases Division, as well as General Internal Medicine, 2 case presentations. So I hope you'll join us then for that session. Thank you very much for attending.